My absolute privilege to introduce Dr. Dana Johnson is coming from Emory. We were just talking about how cold it is here, but I think it's also cold there, but all over the place. But thank you for joining us in December and all of our online guests. Dr. Johnson is an expert in the root causes of health disparities related to sleep and environmental exposures. Has published over 100 papers, is on well over 10 grants, including 2 where she's the lead investigator. And just, yeah, it's on all the things. She's truly an expert in this field. I'm so excited to have her here. So thank you so much.
Thank you so much, Nicole, for inviting me, and thank you to Parker for her organization. I know she's not here now, but there was lots of emails, so I appreciate that. And anyone that was a part of this invitation, I appreciate it. And it's great to see some friends. Andrew and I did our postdocs together way back when, so you know, it wasn't that long ago. But I am truly thankful to be here, and I love talking about sleep, so this is amazing. So how many of us slept last night? Sort of, kind of, almost everybody. So sleep is really important. And so one of the main points that I want to make today is that sleep is this fundamental cause of many outcomes, adverse health outcomes. And so before I get into the lecture, I'm going to tell you a little bit about what I do. Nicole gave you some details, but oftentimes people have not heard of a sleep epidemiologist. So I identify as a sleep epidemiologist. My PhD is in epidemiology, and I train in sleep and circadian disorders. So a lot of what my research does is look at different determinants and health consequences of poor sleep health and sleep disorders. But the other part of what we do is sleep measurement. So I have a scoring lab at Emory where we score actigraphy studies for people that are interested in sleep and may not do sleep as a primary area of interest. So they work with my group and we do all the processing for their sleep data. We also work a lot on measurement. We're doing home demos, dim light melatonin onset. So everything measurement is a lot of what we focus on. And so I think about my work kind of within 2 different buckets, but they often intersect. So a large part of what I do is focus on sleep disparities with this idea that sleep is this intervention point where we could likely reduce health inequities. And so within that realm, I study contextual factors, so thinking about environmental injustices and how that contributes to poor sleep health. I think about and work with the populations that are most at risk for poor sleep health, which include African American populations, also those of lower socioeconomic status. And we've started some new work among rural populations. So we have a study to the rural studies. So we're doing a large sleep study there with many folks at the Brigham who are the actual leads. And then I study psychosocial factors, which is what I'll talk about today, looking at specifically race salient stressors in a way to mitigate some of those harmful effects on our sleep. And then, as I described earlier, as epidemiologists, you know, we look a lot at associations. So a lot of my work looks at the association between sleep and health outcomes, mainly in this cardiovascular realm, but I also do some work in the area of cognitive decline, which I'll talk about a little bit today, and then also cancer. So this is a general overview of the work that we do in my sleep epidemiology research group. So I already hinted towards a little bit of what we'll talk about today, but to start, which hopefully, since most of us slept, I won't have to do too much convincing there, but sleep is this important determinant of health. And so we'll talk about why it's important and connected to several health outcomes. And then I'll also talk about sleep inequities, particularly racial and ethnic. That's where a lot of my work sits. And then talk about some of those contributors, which are really multi-level. So thinking about how there are individual, households, neighborhood, and societal level contributors to sleep health disparities. And then lastly, I'll really make this case about how sleep is this point of intervention. Talk a little bit about what we can potentially do. So I really like this definition of sleep that was published a few years ago, which reads, sleep is a non-negotiable biological state required for the maintenance of human life and it parallels our need for air, food, and water. And so as a public health professional, we're often taught about diet and exercise, really important. But I really want us to think about sleep when we think about these important health behaviors. So thinking about 3 pillars of health being diet, physical activity, and sleep. And so when we sleep, there are important activities that happen, physiologic things that are necessary for our health. And so one piece is when we sleep, this is when our memories get consolidated. And so I often tell my students in class, this is why all-nighters do not work. You will not retain the information. You have to sleep for it to actually work. So it helps with the learning piece. It's also really important for our emotional regulation. I'm sure we can all think about a time that we were sleep deprived and we were maybe a little bit irritable, a little snappy. That happens often when there's sleep deprivation. It's also really important for our immune and inflammatory function. It helps us fight off things like colds, important for our metabolism. Also, cardiovascular regulation. When we sleep, this is when we have our healing and repairing to our blood vessels. And then also for performance overall. And we're seeing a lot of work in the area of sleep among with athletes. And we see how critical it is. Many teams have sleep and circadian experts that work with them. So when they're flying across time zones to help them optimize their performance. So it's really key for all occupations, but just giving the example of athletes. So here's a table just showing the required sleep according to the evidence across the lifespan. So we see that younger people need the most sleep, and then it starts to decrease as we age. And so for adults, healthy sleep, the requirement is between 7 and 8 hours. But we see that adults sleep less, which is really an important question of research. And so there are different things that happen during the aging. There's comorbidities, there are medications and other things that can likely contribute, but it's really an area of research to understand why, particularly among older adults, they sleep less. And so it's important when we talk about sleep to also talk about circadian health. And so we have all these clocks that control different parts of our system, particularly the sleep-wake cycle as one, which gets entrained from the light-dark cycle. And so here is just showing all these different, and this is just an example, there are others, how our circadian rhythms can really control our sleep quality, our mood, metabolism, our blood pressure is on a 24-hour cycle. We have this dipping that happens, that should happen at night, but there's non-dipping that happens for some populations, particular African Americans. And so when we have a disruption in the circadian system, which can happen from shift work, jet lag, I woke up at 3 a.m. this time, so the disruption there, aging that I talked about, and even erratic lifestyle, and then that leads to this disruption in these different systems, so poor sleep quality, also hypertension, and others. And so there are different ways in which it can be improved, and these are just some examples here. And so again, as epidemiologists, we think a lot about the prevalence, how many people are affected by these different conditions. And so these are just a few examples. So some of the most common sleep disorders include insomnia and sleep apnea. Insomnia, a condition in which there's a problem with either initiating or maintaining sleep several times a week. And it affects about 30% of the population in terms of adults have insomnia symptoms. Now, the prevalence of sleep apnea is about 7%, but I put this larger range here to show how much of a variation it is dependent on so many social demographic variables. For example, some of the work that we do in Jackson, Mississippi, among a large population of Black adults, we saw that 76% had mild sleep apnea, so meaning at least 5 times they have these pauses in breathing. And then when we looked at moderate to severe, so more than 15 times per hour of the sleep cycle, it was 35%. And so we're seeing this, that's one study, but we're seeing this across studies. And so similarly, there's other populations that also have a really high prevalence of sleep apnea. So when we group this and talk about a population level, we really miss that opportunity to identify these subgroup other populations that are actually have a much higher prevalence. So I wanted to make sure that was reflected there. And then there's periodic limb movements, restless legs, that affects about 10%. And then here for circadian rhythm disorders, I have, in the literature it says 3%, but I have this question mark because it's not really studied at a population level. And so often there's lab studies and there's inferences that could be made about estimates, but I don't know if we truly know how many people are truly affected by circadian rhythm disorders, particularly given how many shift workers there are in our population and so on. So I truly think this is an underestimate. And then we'll talk about different dimensions of sleep health. But when I talk about sleep health, I'm thinking about multiple dimensions. So sleep regularity, duration, satisfaction, alertness, and timing. And so here's just some examples from population levels that shows about 40% of adults have short sleep duration and 25% encounter sleep difficulties, which often mirror insomnia symptoms. And so all of these are directly in, there's some pathways here in which they're leading to these different health outcomes, including affecting our quality of life, but at the extreme are associated with mortality and likely operating through different mechanisms like metabolism, inflammation, oxidative stress, and autonomic function. And so here's just a slide about sleep health that I described as this multidimensional construct that's adapted to the individual, social, and environmental circumstances. And this is using the Dan Bicey model of Are You Sated, which is an actual scale. So you can measure this in your study and get an idea of where someone sits in terms of their sleep health. And depending on where you fall, it's either associated with good health or poor health. But I wanted to make sure we talked about these different dimensions because often our research mainly focuses on duration, which I will talk about, but I truly believe that a lot of the literature focused here because it's easy to measure. Also a little bit more complicated than that, but it's the ease of measurement. People are putting it in larger surveys easily. However, there's data, particularly in the cardiovascular realm, that shows that sleep regularity is actually a more important marker of cardiovascular, meaning there's stronger associations than sleep duration. And so it's important to think about all these different components and how they also may overlap. So you could sleep for 8 hours or 7 hours, but there may be a later sleep timing, which is associated with worse cardiovascular health, or you might actually have a lower sleep efficiency. So one marker doesn't indicate good health, sleep health. So we want to make sure we consider all the others. And so sleep is not equitable. And so for the sake of this presentation, when I'm talking about sleep disparities, I'm talking about race as a social construct, not biological. So how someone navigates this world and the experiences they have based on how they present. And so really this marker of experiences of racism and not genetically. And so here's a definition of a sleep health disparity that many of us use in the field, which talks about this difference and those different dimensions that we mentioned of sleep health, but that adversely affect designated populations. And so when the good way that I think about it is this disparity is typically due to something that's unfair and unjust. And so NIH has determined what these designated populations are. And so here are the historically minoritized groups that are recognized per NIH as health disparity populations. And then additionally, these are the other groups in addition to race and ethnicity that encounter disparities, so sexual and gender minoritized individuals, socioeconomically disadvantaged groups, underserved rural populations, and people with disabilities, which was added about a year ago. And so in terms of sleep health, the literature is really limited among looking at people with disabilities with a sleep health and equity perspective. So another point of research. But I want to challenge that definition a little bit. So my colleagues and I published a paper recently looking at sleep health inequities in vulnerable populations that are not considered those that encounter health or sleep disparities, but health disparities overall per NIH. And that includes people who experience homelessness, refugee populations, and also incarcerated individuals. And so from this review that we conducted, there's actually a really high prevalence of insomnia in these populations. And then they often encounter many threats to safety, whether it's incarcerated individuals, whether it's those that are living in shelters overnight. And then there are challenges, not just with sleeping, which is, probably an obvious point. It's hard to sleep in environments that are crowded and you have to be vigilant within those settings, but also for those who may have sleep apnea, although there are regulations and policies for different prisons, oftentimes people are not extended the opportunity to have CPAP and have a place to store it safely and plug it in for the amount of hours that are required. So you see a lot of undiagnosed sleep apnea. And so we are calling these vulnerable populations, but I would argue that these are populations that are encountering disparities. So this is due to unjust and unfair circumstances. And so just to give you an idea of some of these disparities, so we know that historically minoritized individuals have a higher prevalence of sleep disorders, but they also occur at an earlier age of onset, which translates to a longer duration of disease. And we also see that childhood sleep is predictive of adult sleep, so these disparities are persisting over time and across the life course. So here's a table from a paper we published several years ago. It was in 2019. This paper came out that I led. However, it's still very relevant. So we see, and there's one change that I will highlight, but in general, at the time that we published this, Asian, Black, Hispanic, Latino, and Native Hawaiian Pacific Islanders all had shorter sleep duration. Now, I talked about short sleep, but long sleep duration is also associated with adverse health outcomes. But it's a little bit more complicated than that because there's data that shows following sleep deprivation, a long sleep period can actually be a good thing for the body. However, when we are not measuring this objectively using actigraphy, and when we're asking people, we don't know if these periods have followed deprivation or not. So in general, long sleep is associated with worse health outcomes, and there were data at the time that showed American Indian and Alaskan Natives had longer sleep duration. There's recent papers that are now showing shorter sleep duration in comparison to non-Hispanic white individuals. So the data, the dashed lines represent there were not enough individuals in these studies in order to make conclusions. So while these groups are included less often in research periods, and also within sleep health research or sleep research in general, there are groups that are included even to a lesser extent, which include Native Hawaiian, Pacific Islanders, and American Indian, Alaskan Natives. So again, pointing to areas that are important or groups that are really important for us to understand sleep, particularly given the high prevalence of obesity in some of these populations. So there's likely a higher prevalence of sleep apnea. So for sleep quality, we found for Asian and Black individuals, it was poor sleep quality. But for Hispanic, Latino individuals, the data were mixed. And this really points to this idea of going back to this definition of race as a social construct. So depending on how you present to society may determine what your experiences are with discrimination, and thus actually measuring discrimination or racism as opposed to race is really advantageous there. But because of the study of Latinos and the Hispanic Community Health Survey, we do know that in general, there's poor sleep quality, and it does vary based on country of origin, acculturation, and other factors. So across these groups, we saw worse sleep apnea. And then also for insomnia, the data were mixed for Black individuals. However, now consistently from some of the work we've done, we have shown that that insomnia symptoms are actually higher in Black individuals. And so we've done some qualitative research to understand this. And so what we found that Black individuals are less likely to complain about sleep. And so it often gets underestimated, which really goes to sleep being stigmatized as lazy in this population. And so when we were doing these actigraphy studies, I remember during my postdoc and reading all these studies that said that insomnia was low in Black adults. It just didn't make sense because the actigraphy studies showed longer sleep latency and more WASO and more lower sleep efficiency. So it clearly couldn't be true. And so, which again points to measurement error there. And so just to quantify some of these disparities for you, we see about an hour difference on average. But again, if we drill down and we think about intersectionality, we see about 2-hour difference in sleep duration between white women who have the longer sleep duration and Black men who have the shortest sleep duration. So the average is about 5 hours for Black men. The prevalence varies depending on which group we're talking about, but between 5 and 86% higher prevalence of sleep apnea. We also see a twofold greater odds of severe sleep apnea and chronic insomnia. And so often when you're looking just at sleep apnea in general, you see smaller differences. But when you start categorizing based on severity, we actually see the most severe in that severe sleep apnea group. And then there's one study, so insomnia with short sleep is this unique phenotype that has really emerged, I would say probably in the last 10 years or so, and we're seeing more associations with hypertension and cardiovascular disease. So it's a study that shows that Black individuals have about a 67% higher risk of insomnia with short sleep. So you're, again, insomnia, this condition where you have this problem initiating and staying asleep, and then you couple that with short sleep duration. And while I'm not showing you data today, but we have an analysis where we see that having the combination of this is more severe than having insomnia alone or short sleep alone. And we also see a twofold greater odds of delayed sleep timing. So if you've seen any of my talks, I always have this in here because it's important for us to not conflate low income with race. And so the important question that many people ask that study disparities is why? Why are we seeing this? So for all the public health people, if you were trained around the time I was trained, the answer was it was SES. It was the fundamental causes theory from Bruce Link and others at Columbia. They said the fundamental causes of disparities is socioeconomic status. And so I'll show you, yes, I have 2 different slides, but know that there are other data that also support this. So here's some data among 100,000 individuals from that were part of the NHIS study, which is a national representative study of adults in the US. Here we have the prevalence of short sleep duration by occupation, professional, support, and laborers. So we can think about this as high, middle, and low. The blue line represents Black individuals, the orange Latino, and the gray white individuals. Then we have men on the left and women on the right. So we see that the greatest disparity is actually in this higher group, professionals. So we see that the highest prevalence of short sleep duration for men and women is actually Black individuals that are professionals. We see a similar gradient for Latino individuals, for men and women, that those that are professionals have a higher prevalence or short sleep duration in comparison to laborers of the same race. But it's a totally opposite gradient if we look at the white individuals. It's typically what we're taught. Higher SES is associated with more resources, so you'll have better health. And that's what we see for white individuals. So the professionals, what we expect, have the lowest prevalence, a short sleep duration, and their laborers have the highest. So we look at the laborers and you look at women, there's really no difference, no Black-white difference. And in my talk that I give on contextual factors, we see the same thing in environments. So when you live in similar environments that are low income, there are no differences in sleep. And oftentimes white individuals have worse sleep in lower income areas. But when we look at the higher income areas, we see much more of a disparity. So again, showing you the greatest disparity here is actually at higher socioeconomic status. So you'll say that's one study. Let's look at another measure of socioeconomic status. This is looking at education and the predicted probability of short sleep. So we have white individuals, Black and Hispanic. Now the gradients aren't as stark, but they're still in the same direction. So we see here for white individuals as they grow in education. So the yellow line is college, and then the gray is some college, and then orange is high school, and then the blue is less than high school. So we see as they grow in education, the predicted probability of short sleep decreases. But the opposite is true for Black and Hispanic individuals. So the more education, they actually grow in the predicted probability of short sleep. And so there's another example with income, there's on and on. But you get the point here. We're actually seeing worse sleep among higher SES Black individuals. Why do you think that is?
Pressure is higher on them.
Pressure is higher.
The journey was harder.
The journey
More
is much
stress.
harder.
More stress.
More stress, exactly. So there's these additional factors that are contributing. And then they're also more likely to work in environments in which they are the minority, as opposed to the lower income individuals who tend to work with people of the same race. And so you encounter more microaggressions, more experiences that are a reflection of redlining and so on, lack of generational wealth, and trying upward mobility. There's more challenges there. So the point here is SES alone is not protective of sleep, for minoritized individuals. So again, as we think these environments come with more resources, which they do, they also come with more stressors and other factors that are actually contrary to having healthy sleep. We're actually seeing worse sleep in these populations, which are due to all these factors you have named, and I just listed some of those below. So in general, when we're talking about these different determinants of sleep and circadian disparities across the lifespan, which are truly multifactorial, there are social factors, and we talked about some, including discrimination and stress, socioeconomic status, but also environmental factors where a lot of my work sits. We're living in certain environments that we call sleep deserts that are just not conducive for healthy sleep, tend to have more inopportune light exposure, noise, even violence, and toxins, air pollution in particular. And then there's sleep-related behaviors. And so while at the surface, these seem like individual, I like to give this example for consistent bedtimes. This is really a function of societal laws and policies. So for example, minimum wage is not a livable wage. And so if you're working a job that's a minimum wage and you have a family, you might need multiple jobs. Or if you live in California, you might need multiple jobs if you're working a minimum wage job. So you may not be home to implement a consistent bedtime routine or do that for your child. And so while we may direct interventions here, it's not going to change unless we address societal things. So that's what I mean in terms of multi-level and multifactorial. So these can individually and cumulatively contribute to disparities. And so when we think about the root cause, I'm not going to go through all of these, I'll just put it up. This is a nice a figure that the American Heart Association published a few years ago, which talks about, but really lays out how structural racism is the fundamental cause for health inequities. And so in their example, they have cardiovascular inequities, but I nicely added sleep for our purposes, of course. But they started back to slavery just to show how this led to these different systems, such as Jim Crow laws and segregation and redlining, where we see current day outcomes. You have a great colleague here, Lynn Messer, who did a lot of that early work on neighborhood disadvantage and has many measures of structural racism that her group uses. And so that leads to these concentrated poverty and social determinants, which we are more familiar with here. So poor access to healthcare and housing, poorly funded schools, and poor access to capital. And so here I show how this can lead to, but really I can have all of these arrows leading to sleep problems, but we'll just show poor access to care. And so within my work, I think about sleep as this pathway here. And so the American Heart Association, the authors of this paper, just led from social determinants to heart disease. But I believe it operates through sleep as one of the many mechanisms, right? And so we have data showing that increased sleep disorders lead to increased heart disease, toxic stress, and then that leads to the increased burden of heart disease and stroke, and also worse cardiovascular and stroke outcomes. And so this is just showing that pathway and leading or starting with structural racism and how that leads to these worse health outcomes. And so I want to talk a little bit about stress and then show you some data. Stress as a contributor to sleep health and health disparities. And so this is just a conceptual framework that I use in my work and thinking about these different psychosocial factors, particularly discrimination, microaggressions, and perceived stress, and how that leads to sleep. But through our work, both empirical epi studies as well as qualitative work that we have done, we've heard from our participants about rumination. So they talk about experiencing different microaggressions during the day and thinking about it at night. And so that's that idea of rumination where you're constantly thinking about it. And so we know that can impact the initiation of sleep. You also see more increased arousals and then also an increase in hormones. So I want to show you some data from Cardia, which is a cardiovascular cohort study. And so for this particular study, we were interested in not just looking at stress, but how much of a burden is the stress that you're experiencing. And so there are measures of sleep, actigraphy, and self-reported in this data set. And there's newer data that just came out. So now we're doing some longitudinal associations with their new sleep study. And then there's data on metabolic syndrome. So we have prevalent data and also incident data. But for today, I'm just showing you the prevalence data. So the sample is about 600 adults that are about 40 at the time of the analysis, or at the time that the data were collected. They were 40 years of age on average. 43% are Black, so the study is of Black and white adults. And 53% have a college degree. And so we fit some logistic regression models and stratified by race. And for the incidents, we did Cox proportional hazard models. But first, to show you the data for chronic burden and sleep. So here we found associations only among Black individuals, not white individuals. So in particular, Black adults who experience either medium or high chronic burden. So this is having the burden of stress for more than 6 months was the definition in the measure. It was associated with a twofold greater odds of self-reported sleep, short sleep duration, less than 6 hours, and then also worse sleep quality. Now, there were no associations when we looked at objectively measured sleep actigraphy, but we see it for these self-reported measures, and we hypothesize, and others have as well, that oftentimes the way in which the measures are collected tend to map together. So self-reported exposures tend to match with self-reported outcomes. Now, we do have other data that shows there are associations with objectively measured sleep, but however, that was the finding here. And there were no associations between chronic burden and sleep for the white individuals in the study. And then when we looked at, so our interest was understanding if sleep mediated the association between chronic burden and metabolic syndrome. Now, while chronic burden was associated with metabolic syndrome, so you can see here for those who had high chronic burden, it was associated with about 94% higher odds of metabolic syndrome. Sleep did not change that estimate here. So there was no association between sleep and metabolic syndrome. Now, this is again why it's important to parse out data. So when we parse out the definition of metabolic syndrome, we actually saw the association was with blood pressure and none of the other measures of metabolic syndrome. And so then we did another analysis using data from MIDAS, which is also a cardiovascular related study. There's lots of measures in MIDAS, but it's a study of adults, different sites across the US. But for the sleep data, These participants were in Wisconsin. And so here we found that individuals who had a low sleep efficiency, this is measured objectively, we saw that there was a higher odds of hypertension. It was also associated with a higher systolic and diastolic blood pressure. So consistently, we're seeing these measures with blood pressure, but not with metabolic syndrome. Interesting. But there are others that have published and found associations between sleep and metabolic syndrome. So I'm not sure exactly what's happening there, but we're consistently seeing this signal with blood pressure, which again is this, or hypertension in particular, is most prevalent among Black adults. They're also most likely to have uncontrolled hypertension. So here's some data for a paper I was not involved with, but again, I want to drive this point home about sleep as this point of intervention. So here they looked at sleep as a mediator of cardiometabolic disease, and they did a formal mediation analysis. And so this is the race effect here. So here they found racial differences in cardiometabolic disease for Black and white individuals. And then when sleep was added to this model, we see that the association was attenuated and no longer significant. Same for sleep efficiency. When it's added to the model, we see even more of an attenuation and it's no longer significant. And from their formal mediation analysis, they found that sleep duration explained 41% of the racial difference in cardiometabolic disease. And for sleep efficiency, explained 58%. That's a really high percentage. So if we can potentially intervene there, sorry, it was hard for you to see there. If we can intervene there and improve sleep in these populations, we can potentially reduce this racial disparity that we're seeing in cardiometabolic disease. So let's talk about sleep as this point of intervention. So I want to show some data from Jackson Heart Study. This is data that are analysis that is in progress real time. So if you have feedback, you have thoughts, definitely let me know. So I love to talk about the work in progress to get feedback. So at the beginning of the presentation, I talked about these 3 pillars of health, right? Physical activity, diet, and exercise. We're not gonna talk about diet right now, let's just talk about physical activity. But a question that in the last 2 or 3 years when I've done interviews, people keep asking is, what's better? Should I exercise or should I sleep? Now I'm biased, so I'm gonna tell you to sleep, but I thought maybe I should really understand what the data show and not just my bias that I admit. And so here we were interested in understanding about the reduction in hypertension burden by potentially targeting these different behaviors, including physical activity and sleep. So yes, sleep is a physiologic activity, but also think about it as a health behavior. So here's our research aim. It was to estimate how reallocating time spent in one movement behavior for another influences hypertension and hypertension control while accounting for the remaining movement behaviors among Black adults in the Jackson Heart Study. How many of you are familiar with isotemporal models? Okay, this is new for everybody. Okay, good. I have an example, so I was expecting that. So isotemporal models, they estimate associations between theoretically substituting one type of behavior for another. So in this example is physical activity and sleep. So this is from a published paper here. I think they were looking at obesity, but I really like this figure and figure I would show it as this example. So we think about our 24-hour day, think about how your time is spent. Hopefully a third of it is spent asleep. And then you're doing other stuff, during that. So right now you're all sedentary because you're listening to me talk, right? So here for this idea of isotemporal models or reallocation models, composition modeling is another way to talk about it. So it basically statistically estimates if we trade off, in this example, 30 minutes of sedentary time for physical activity, what happens on the health outcome? Or if we trade sedentary behavior for sleep, what happens on health outcomes? Same for moderate to vigorous physical activity. So it's just reallocating that time spent on a health outcome, okay? We're good, right? Okay. So we are using data from the Jackson Heart Study, which is a large cardiovascular cohort study in Jackson, Mississippi, which, interesting, I used for my dissertation, then my postdoc, and then in my faculty career, and I still use Jackson data So the sleep study was collected between 2012 and 2016. And so now there's 3 exams. And they're in the 4th exam right now doing data collection. So we'll have newer data coming out soon. But for the sleep study, we enrolled 900 Black adults in Jackson, Mississippi. We did in-home sleep apnea testing, 7-day actigraphy. We brought them into the Jackson Mall for a clinic visit. We had blood pressure measurements and so on and so on. Lots of data. Interested in analyzing it, please reach out to me. And so for this analysis, we used EpiCoda to compute these isotemporal substitution models, which again, I already gave you this idea that is hypothetically reallocating these behaviors. So I keep saying hypothetically because we didn't actually test this. We're modeling what would happen. So for this analysis, we have 2 different cohorts here. We have the individuals that were in the actual Jackson sleep study where we have actigraphy, but we wanted a larger sample to also replicate the results in. So we used self-reported sleep also from their 3rd exam, which has almost 4,000 individuals. The sample at collection was 63 years of age. 68% are college educated. 65% are female. 83% have a hypertension. So that was one of the reasons why we looked at hypertension control, because most of the population has hypertension in Jackson. And again, you see the college education here. So we're not just talking about low SES, right? And so on average for the actigraphy measured sleep, it was 6.67 hours on average. For self-reported sleep, it was about 7 hours, which is consistent. Self-reported is about an hour over estimate of objectively measured sleep. Light physical activity was 11 minutes, and then there was 30 minutes of moderate to vigorous physical activity, which we checked and rechecked and rechecked because we thought, oh my God, they're really, really, really active. And so that was right. So I'll walk you through these results. So here is a table of the results. So it's showing if we decrease any of these behaviors up top, so light physical activity, moderate to vigorous physical activity, sleep duration, and sedentary time, and increase these different same behaviors. So this is showing for uncontrolled hypertension. What is the effect on uncontrolled hypertension? So here, thank God for what I've been saying, but I'll show you some other data that actually doesn't support it. If we reduce sedentary time and replace it 30 minutes with sleep duration, we will lower the odds of uncontrolled hypertension by 7% among Black adults. So this is showing this trade-off of sedentary time for sleep duration. So for uncontrolled hypertension or high blood pressure, we did not see any associations if we traded off the sedentary time for physical activity. And then we replicated this and looked at it for hypertension, and the results are very different. Actually show for physical activity. So including trading off sleep for exercise, it was actually associated with lowering the odds of hypertension. So if you reallocate 30 minutes of sleep or sedentary time for moderate to vigorous physical activity, it lowered the prevalence of hypertension by 13% for both. So you all on this side can see. So we used the 2 different definitions for hypertension because at the time the data were collected, there was one definition, the 140/90, then it changed to 130/80. So the results are consistent for both. Actually, for light physical activity, you start to see a signal using the JNC set definition. But here we're seeing consistently across both that sleep and physical activity are better. But we're seeing here for hypertension that physical activity, a trade-off of sedentary time for physical activity had more of an influence. But for hypertension control, we could see sleep. Now, what I would do in our next analysis is actually look at the position of the timing. So I think that actually matters if we think about the circadian rhythm. So perhaps the trade-off for sleep or physical activity is at a certain timing. I'm not sure, but I think it's important to look at because for a while the data showed that physical activity at night was not actually good for you, but it actually depends on your circadian rhythm. And so I think that's important to consider. So that's a limitation of this work. We're not actually looking at the time of day, which we could do in another analysis. Okay, so I'm going to end with just showing you some data for cognition. And so here, so bringing in some of the work that I do and looking at environmental measures. So I showed you data around stress and sleep, and then in cardiometabolic outcomes. And now I want to show you the same for cognition, because this is about several health outcomes. Sleep is connected to many. So adverse housing conditions, which can either be the function of the home or a reflection of the outside environment, can have adverse environmental exposures such as air pollution. There could be more noise, crowding, and so on. So there's data that shows that it affects cognition. And then there's emerging data that suggests that housing is associated with adverse sleep health, which is actually my R01 study focuses on indoor environmental factors and how it affects circadian rhythms and sleep. So here we were interested in testing if sleep mediated some of the associations between housing and cognition. And so for the methods, we fit some logistic regression models. For the mediation, we used R and did bootstraps, model-based causal mediation analysis, and adjusted for some covariates. And so on average, we had about 2,300 that were included in the sample. It's data from the Health Retirement Survey. And so this is all self-reported data except for the cognitive outcomes. We have both objective and subjective. The sample is about 66 years of age on average, 56 are female, it's 80% white, and about 25% had subjective cognitive impairment based on questionnaires. But once we measured, or they measured in the study I analyzed, about 34% had objectively measured cognitive impairment. And we saw poor housing, about 77%, and then 38% had sleep disturbances. Yes.
Can you go back and just define
Sure.
a little bit more about the housing, if you have any information?
Yes, it's a very crude single item question that asks a person to rate their housing quality. Yes, so it's a crude measure of housing. Mm-hmm. Yes, no worries. But we'll have more from migraines since we're actually measuring it. Okay, and so it's probably, there's differences here because clearly there's going to be some measurement bias in the housing report. If you're used to living in that type of circumstance, you likely were rated better than what it actually could be. So here, this is showing the association between housing and sleep disturbances. And here we found that individuals who reported their housing as fair or poor in comparison to excellent, they had a higher odds of sleep disturbances. But again, remember that sample was quite small, which is why there's a wider confidence interval here, but still not too wide. And then again, the same, this is just showing the partially adjusted and the fully adjusted. But for those that were in the better categories, there were no associations between housing and sleep, which we expected. And so in terms of sleep and cognitive function, we saw in both the partially adjusted and the fully adjusted models that sleep was associated, or sleep disturbances were associated with a higher odds of cognitive impairment, whether it was measured subjectively or objectively. Here, they're actually, it crosses one, so there was no association in this, but the trend is there in the partially adjusted, but we see the association in the fully adjusted model. And so once we did our formal mediation analysis, we saw that, so this is showing the different adjustments. And so here in this larger, the higher part of the plot, we see once we include sleep disturbances, we see an attenuation of the estimate for both. So here it's smaller for the objective measured, it's larger for the subjective, but we see that sleep mediated about 15% of that difference in housing and subjective cognitive impairment. Excuse me. And for objective, it mediated about 9% sleep disturbances between housing and cognitive impairment. So it's smaller than what I showed you for the cardiovascular outcomes, but still similarly showing that sleep likely has this association. And here we're looking at an environmental exposure. Excuse me. And so in summary, we see that there are sleep disparities that are patterned by race, ethnicity, as well as socioeconomic status, not in the direction that you would expect. But again, that they're showing the importance of having an intersectional perspective to doing research. Structural factors are the root cause. So thinking about not just structural racism, but how that led to present day residential segregation and the housing environment where people currently live. And then sleep contributes to health outcomes. It shows you data that's associated with hypertension as well as cognitive impairment. And thus intervening on sleep may help to improve sleep and reduce health inequities. So I just want to highlight the collaborators from the research that I showed today, and thank you for your time. I'm going to put it back on the summary slide for questions.
Thank you, Dina, for that tour de force.
So you mentioned that sleep early in life could have long-term consequences. What your thoughts are on how much of like sleep quality and duration and things are kind of like a learned behavior, whether sleep improves or doesn't change upon retirement?
Yeah, great question. So if we take your first part, I absolutely think it's a learned behavior. I think it's part of your environment. Just if you experience certain foods for the longest, you get used to eating in that certain way. And so there's not a lot of empirical evidence that supports that. There are a few studies that shows the patterning of sleep behaviors. Most of the data is looking at that trajectory of childhood sleep through adolescence and adulthood and seeing that the pattern is consistent. But I absolutely believe in those patterns, and it could potentially change once that person leaves the home. But we see across health behaviors that the patterns usually persist. And then the second part about retirement. Can you repeat that part of the question?
So you showed a lot of work showing that the type of job they do has different effects on what a person's lack.
Yeah.
But once they retire, are they sleeping the same, or are those same differences persisting?
Yes, good question. So I don't think we've actually tested that. So we have done other trajectories of once you're out of the workplace. So for example, with discrimination, if your experiences change, does it affect your sleep? And we do see that there could be an improvement following across years. So we've looked at that. But in terms of once retirement, but it's a question that we could definitely look at. My thought is that it probably persists, particularly because it becomes this behavior. But I will say we see that sleep is different on weekdays and weekends, right? So weekend sleep tends to be longer. You don't have to get up. So it all depends on how much of that pattern was established. Is the person still getting up during the week? Are they doing something else or not? But the data does show, and even from the pandemic, if you have the opportunity for longer sleep, aside from environmental disturbances, you usually sleep longer. But we see, as I started in the beginning, talking about how sleep is actually declines among adults, there's other factors that start coming in. So it might actually be a little tougher actually to disentangle that because of all these other things that are happening. I think the way to answer that is looking among normal sleepers or people that get the recommended amount, and then seeing, or at that current time, and then seeing maybe over time what changes, but thinking more about sleep as the resilience factor, I think would be the way. Let's talk about that more at dinner. I want to think about it.
So when you started the talk, you listed all the NIH minoritized groups. And I think you had a slide that showed that minoritized groups generally have poor sleep. Is that correct?
Yes,
Okay.
correct.
Okay, so my question is, the structural racism and the slide that you showed, Black Americans, which we know is, quite an extreme history of racism
Yes.
leading to current day outcomes. But if you took Asian Americans
Mhm.
and you look at their outcomes, they've had a different experience. I don't know if you've looked at other groups, but I'm curious, how these various systems of oppression or racism or however you describe it, I mean, every group has a different experience.
Yes.
And different SES.
Yes.
And so what do you make of, the fact that all these groups have lower
Yes,
sleep?
yes, great question. I'm smiling because literally I wrote a grant this week to look at this and other calculations, right? So like I've been thinking a lot about this. Yeah, right. So this is where I lean on my colleagues in sociology who I think are really equipped to do this work. And through some of the conversations we've been having, it is consistent because so in my neighborhoods talk, I also talk about immigrant populations. So the same experience happened so the structural racism isn't specific to just Black individuals. We often talk about Black individuals because of slavery specifically, but those effects and laws affected many people that were denied living in certain areas. So it's that barrier to that generational wealth, or you lived in environments which was deemed not worthy of investment. So, while it might be different, there's the same exposures. Now, we wrote a commentary like maybe 2 years ago, maybe 3 years ago about the model minority, where we talk about sleep among Asian populations. The same thing, encounter stressors. It's just a different reason. Now, we see in some cases better health outcomes. And for sleep apnea, for some of the higher prevalence in sleep apnea for Asian populations is a reflection of the actual structure of the air passage. So it's not social determinants per se, it's a more narrow air passage. For other groups, it's different. So I think in terms of like the environmental patterning, living in certain areas where you have a higher, or in food deserts specifically, and you can see this higher prevalence of obesity, I think that's one of those connections that are leading to worse sleep apnea in those populations, which again is that reflection of residential segregation. So I think it's similar, but we're actually working right now. We've had this working group at Emory on structural racism that I lead. And so we've been talking through making this conceptual framework for other populations and actually pulling in empirical data to support it. And on the plane here, I finished the grant. But I'll be going in around to fund some of that work and defining it and seeing how it relates, because I think it might, there's going to be some caveats that are different, but for some groups, they would start at colonialism. So they're talking about, how the start just might be different, but the consequences are the same.
Thank you.
Mm-hmm. Yeah, great.
More. I do Doris and
So I was wondering, how much is it really sleep or relaxed time, let's say?
Yeah, that's really interesting.
Can I
So
not sleep, but will I wake while
okay, well, so I'm gonna act like you said something slightly different so I can make the point about the sedentary time, but I'll come back to it. So we have data that shows just resting in the sitting position doesn't work, right? Like the actual sleep and going through REM and non-REM, where we go back to that second slide where I talk about the physiologic aspects that occur when we sleep is important. We have this dipping in our blood pressure. We need that rest. So the question about lying down, I think it has an impact on health outcomes, absolutely, depending on what you're lying there. Are you thinking though? And your mind is still going, and so you would not have a positive outcome because when I'm laying down, I'm thinking about my to-do list, I'm thinking about all those things. So hopefully when I'm sleeping, I'm not thinking through that. My brain is active, right? So it could be, but what if you're just relaxing? I think there are some benefits to that. I think that's a whole study to look at, right? Yeah, but I do think there's a specific purpose, that's evidence-based that shows that the actual sleeping process is what's beneficial. But the question would be, how beneficial are naps? You're not going through 90 minutes. Your nap is supposed to be 20 minutes. People just have to know that you're not supposed to nap longer than 20 minutes. So, and people feel better. So I also think I made this point about objective measures, but I also think, I showed you the sleep health framework that sleep satisfaction is one of the components. And so that's why snooze makes people feel better. Does it do anything for your sleep? I mean, no. 9 minutes, it really probably didn't. But people feel better when they hit snooze. So if it makes you feel better, go for it, right? But I still want people to sleep longer. I mean, I'd rather just set my alarm for the time I actually got to get up so nothing interrupts me. But, feel free to email me questions or anything. And we didn't look at the chat. No idea if that was people. But thank you, online people. Yes, but I see you later. The great question. Yes. Oh, yes, please do. Just send me an email.